Well, thanks, Joe. Fascinating stuff and a lot of work ahead of all of us. We're going to move into the second day of the meeting now, and we're going to start off with total hip replacement and look at the anterior approach versus the posterior approach. I want to remind all faculty, if they can, to keep their camera on while they're talking and share their screen, turn it off afterwards and move on to the next person. For anybody listening, if you have questions, please post them in the chat box or the question box, and we'll get to them after each session. So first off is Dr. Darwin Chen from Mount Sinai, and he'll speak about the anterior approach. Thank you, Darwin.
Can everyone see my screen and hear me? Hopefully.
Yes. Yes.
Great. All right. So good afternoon. My name is Darwin Chen. I'm associate professor at Mount Sinai in New York City. We'll lead off tonight's talks with a classic debate on total hip replacement about surgical approaches. I'll present on the direct anterior approach. Is it the new standard in hip replacement or a passing fad? And my counterpart, friend, and practice partner, Dr. Muha, will take the side of posterior approach. These are my disclosures, none of which are relevant to this talk. So total hip arthroplasty has been called the operation of the century, and for a great reason. It's one of the most successful interventions in all of medicine and provides our patients suffering from hip arthritis with predictable and often dramatic functional improvement and pain relief. Now, I think of modern surgical approaches to the hip in three categories. There's posterior, anterior-based, and the anterolateral and lateral variants. And each one of these has pluses and minuses. There's really no free lunch when it comes to how you enter the hip joint, and no approach is perfect. And the reality is that all surgical approaches inherently cause collateral damage. Yet all these approaches can still produce great clinical outcomes. In fact, I credit Dr. Muha with teaching me how to do a great posterior approach well over 10 years ago when I was his resident. So contrary to popular belief, the anterior approach is really not a new technique. It was first described in 1881 by Karl Heuter in Germany, and Smith Peterson in Boston first used the DA approach for arthroplasty in the 1940s. Now, around the same time in the 40s, the Judet brothers in France devised a mechanical orthopedic table to facilitate the anterior approach hip replacement and perform this acrylic hip arthroplasty, which incidentally failed miserably. These three surgeons can be credited with bringing DA into the modern era. Chris Kege in Connecticut, Michael Nogler in Austria, and Joel Mata in Los Angeles, who I learned the approach from. Now, to me, the direct anterior approach makes the most anatomic sense of any approach to the hip. It's the most superficial from anterior. The anterior approach is a modified Smith-Peet interval, which is really the only internervous and intermuscular interval in the hip. There's no abductor violation, unlike an anterolateral or lateral, so limp is a non-issue. There's no posterior structure violation, which I think minimizes the risk of dislocation. And with DA, we can exploit this natural interval in the hip to do a replacement that I think minimizes surgical insult to the soft tissues. And I'd argue that in DA, the size of the incision doesn't really matter. It's really what goes on underneath the skin that define this as a less invasive technique. Now, the potential benefits of DA are less soft tissue damage, less post-op pain, more rapid recovery, no post-op restrictions, low risk of instability, and more accurate component position. And while these claims are definitely controversial, there's no doubt that anterior approach is on the rise. If you look at this polling data that's done at AAHKS every year, the percentage of DA users increases every year, and it's really now up to 40%. And for better or worse, there's increasing patient demand. I'd argue that even if you are a diehard posterior surgeon, as Colin is, it's still a good idea to have an anterior surgeon in your group or practice, because really some patients will insist on DA and will just keep on doctor shopping until they find someone who does it. And I think direct anterior is absolutely here to stay for the long haul, unlike a lot of the MIS approaches of the past, such as two-incision technique. Perhaps the biggest advantage, in my opinion, is the ability to use the fluoroscopy machine. And with other approaches, you do the surgery mainly by feel and experience. You close the wound, and then you take an x-ray, maybe in PACU, to check how you did. And with DA, you use fluoro real time. I think you can get a good idea of how things are coming in and make sure everything's perfect before you close and leave the OR. And I believe that this ensures accurate and reliable component positioning, a better chance at getting equal leg lengths and perfect socket placement. Faster recovery is, I think, an added bonus, and certainly makes DA a draw for patients. Fluoro aids in cup positioning and can allow you to hit your target inclination and anteversion with better precision. And in this study in particular, the authors showed better precision with fluoro-guided DA versus non-guided posterior approaches. At this point, there's multiple high-quality studies demonstrating improved accuracy of cup positioning with DA. I think this cuts down on outliers, and these inevitably are more frequent from a posterior approach, no matter how good or experienced you are. What about stem side? It's equally valuable on the femur, I think. You can assess your stem position, size, and offset very easily without having to guess or feel anymore. And here you see that the initial broach is in good position, down the pike, but a bit undersized. And going up one size fills the canal and metastasis better and minimizes the risk of subsidence. You can get a good sense of leg length and offset by placing sort of a traditional transitional or trans teardrop line across the pelvis. You can also do overlay or some other new fancy navigation units and computer systems that allow you to calculate this very easily. What about faster recovery? At this point, I think there's very clear evidence that DA does lead to faster early recovery. And in multiple studies at 2 to 4 weeks postoperatively, there's less need for assistive devices, improved gait, improved functional scores, and an earlier return to function. These approaches, I think, do tend to equalize out at 6 to 8 weeks and beyond, but there is a distinct and well-documented early recovery advantage with DA. Is it important in the end? If you ask the surgeon, maybe not, but if you ask the patient, however, probably yes. What about dislocation rates? Is it any lower with DA? The data, I think, is less clear here, but to me does support a small but distinct advantage over posterior approach. Dislocation rates from posterior are probably about 1 to 2% in most series, and comparative series with DA show a dislocation rate of about 1% or lower. And I think this is a combination of improved component positioning and lack of posterior hip structure takedown. What about DA in the wound? Now, the anterior wound is certainly more sensitive to breakdown and potential infection because it's really located more towards the groin and abdomen. In this series by one of our speakers, Dr. Cooper, major and minor wound complications are up to 11%, which is really not insignificant. And this risk is certainly higher with the bad players, the high BMIs, diabetics, and smokers. However, despite an increase of local wound complication rates, it's really unclear if this risk increases the PGI rate, which is really what is important, I think, in the end. And this recent study done at NYU is often cited. It's an award winner, shows 1.2% PGI with DA versus 0.6 with non-anterior approaches. I think the study does have some flaws, which I think confound the results. 45% of DAs were done by low volume surgeons performing under 100 cases per year. And the authors themselves write this may demonstrate an effect of an institution rather than an individual learning curve. What about femoral failures? Direct anterior naysayers will cite increased risk of failures such as fractures and loosening. I think with a hip replacement, any fracture can occur in any type of approach, but with DA, they tend to be a little bit different in terms of the pattern. These can include GT fractures and stem perforations, and I think early loosening can be a problem if you're imperfect with your approach technique, which leads to poor bone implant apposition. This also may be associated with the type of stem you use. And I think the real concern, I think this is a real concern that the literature reflects. I think this is a direct result of the early learning curve effect, so to speak, and inadequate femoral exposure. And certainly this is the most challenging part of getting through the operation. It really should look like the image in the left-hand corner with the femur up and out away from the socket so that you can get a good broach inside. Are there contraindications for DA? For me, if a patient has a very large protuberant abdomen, I typically say no and do these posterior. And in my opinion, I think the risk of the wound is greater in these patients, as well as early femoral failure. The belly's just in the way, and I don't think it's worth it personally, which is arguable. Understand this is not really BMI related, but really more body shape. And the patient who's an apple may have a more issue than a patient that's shaped like a pear. Patients with femoral deformities, I think, may potentially not be appropriate for DA as well. It's a little harder to judge anteversion from DA. In cases of severe dysplasia or Perthes or skiffy patients, these are patients who may be done better through an extensile posterior or anterolateral approach. If you're doing a substroke shortening or changing the version on your stem, I think this is easier to do from a non-DA approach. Placements with prior lateral hardware. I think if you're going through a prior incision to get hardware out, you might as well do the approach and hip replacement through that same incision, so you can avoid the need for potentially 2 separate incisions. So what's my current algorithm? For most standard primary uncomplicated hip replacements, I do an anterior approach. In my practice, this ends up being about 60 to 75% of hips. And I believe a routine hip is still best done through DA. And if I need my hip done in hopefully not, but 20 to 30 years, I want my hip done through DA. I rarely use anterolateral approaches. I do this for training purposes if a resident wants to see it. I do these for older and demented patients for hemiarthroplasties. I definitely do still posterior approaches. This is about 20-25% of my practice. I use these for complicated revisions and complex primaries where you need a larger exposure, and also the large patients who I don't think can tolerate a wound from DA. In conclusion, I think that we'll never settle this debate definitively. Surgical approach like politics and revision is very personal to the surgeon. Today I've shown you that DA is really not a passing fad. I think it's here to stay for the long term. I think DA has distinct advantages with regards to recovery and stability and component positioning that you cannot ignore. Posterior and anterolateral approaches are still tried and true techniques with a long record of clinical success. I think a well-versed hip surgeon should ideally be able to perform all these approaches, whether it be from the front, back, or the side, and ultimately what works best is what the surgeon is most comfortable with. Thanks very much.
Thanks, Darwin. We'll now have the countervailing argument by Dr. Colin Muha, the Chief of Joint Replacement at Mount Sinai Health System. And remember, any questions, please put them in the question box and we'll get to them at the end.
Great, thank you. Can you see my screen?
Not yet. And Darwin, if you can close your webcam.
Sure.
You guys see my screen now?
No.
Sorry guys, I'm not sure what. How about now?
No. Let's see.
Can you guys see my screen now?
Still not. Maybe. Hey, Eric, if you close your webcam, thanks. Yes, there we go.
Okay. All right, thank you. Sorry about that. Can you see it, James?
Yes.
You're good.
Great. All right, thank you. Thank you all for listening. And I want to thank Darwin Chen for a superb presentation. He is as superb a speaker, presenter as he is a surgeon. And I can only take partial credit for one of those things. Today I'm going to talk about why I use the posterior approach for total hip replacement. The ideal surgical approach should be reproducible, simple, with a short, low-risk learning curve. It should be extensile as needed, especially for MIS procedures. Generalizable for patients and surgeons. It should be safe for patients and surgeons, both for surgeon's physical and mental health. It should allow for good pain control, allow to recovery within an acceptable time. It shouldn't affect future revisions. It should allow surgeons to use the implant and fixation of their choice, and it should also have a good track record. All surgical hip approaches have advantages and disadvantages. All of them are better in the hands of experts, especially at high volume experts. All of them have learning curves, but it's more important when a new procedure is adopted after being a trainee. And how well you do the approach is more important than which approach you do. This has been my personal experience so far as I became a surgeon. Basically, I started doing the posterior approach in residency. During fellowship, I did a modified Harding anterolateral approach, and the amazing MIS2 incision approach, where you did the cup through an anterior approach and the stem through a poco posteriorly, and we all know how that did. We also did a large number of posterior approach revision surgeries. Darwin and I both trained at Rush, and we had a great training experience up there in Chicago. During the majority of my almost 18-year career as an attending, I've done the posterior approach, although I did have a 1-year period where I did about 29 direct anterior hips using the DePuy MATA table, as I like to call it. So what was my experience? Well, patients really did not go home any earlier. There was not particularly more satisfied than the posterior approach patients. And I had these 3 complications. I had a wound dehiscence. It happened around 3 weeks. It did not require surgical intervention. I had a periprosthetic fracture, pretty typical fracture. Patient called me around 2 weeks, no trauma. Clearly, it was an intraoperative fracture that I did not recognize on the fluoro images, and even going back, I did not recognize on the fluoro images. And interestingly, I had one leg length discrepancy where the side that I did was significantly longer than the contralateral side, and that was because I just didn't know how to work the stem down. I didn't know, I didn't have all the tricks in my pocket how to get a routine stem down like I would in a posterior approach. We also did a study on Mount Sinai. This is a single surgeon series. It was not Darwin Chen. It was another senior surgeon. 314 direct anteriors, 278 posterior approaches. No advantage in length of stay. At that point, patients were staying about three days in the hospital still. When we did a multivariate analysis, we did see that the direct anterior was protective against extended length of stay, so that's length of stay beyond 4 days. But what we also found was that direct anterior patients were found to be 5.8 times more likely to undergo 1-year revision compared to posterior patients. So again, these were not Darwin Chen's patients, but it was a study that was presented and is up for publication. As a surgeon, I just wasn't impressed. I wasn't satisfied. I was sweaty, I was stinky, I was cranky, I was frustrated. I felt pressured, and I just didn't really have fun. And guess what? Neither did me or my staff. I remember the first case would be an anterior approach, and then if the next 2 cases were posterior, everybody would say, he's back. He's such a nice guy. He's back again. So I kept on asking myself, why? And the answers kept on coming. Why am I doing this? Well, if you look at the studies, John Leopold, Bill Barrett, they did a wonderful study in Journal of Arthroplasty, and the direct anterior surgical time, incision length, blood loss were all increased. There was no statistical significant difference in outcomes at 3, 6, or 12 months. The length of stay was slightly shorter in the direct anterior patients, and as you could see here, these length of stays were not too different than what we were experiencing several years back. We're much lower now. We're down to 1 day for anteriors and posteriors. But interestingly, these patients had different rehab protocols. But the distance walked in the early post-op period was slightly better in the direct anterior. And then there was this other study. This is an interesting study by surgeons that are still doing the anterior approach. So this is Jose Rodriguez at HSS, Matt Heppenstall, I believe he's one of our speakers from joint disease, and Mar Runawat also from HSS. And basically what they showed, this was when they were back at Lenox Hill, that the only statistically significant difference was the TUG, the time up and go test at 2 weeks. So if you really look at the nitty-gritty data here, that was the only one that was significant. This other study from a core direct anterior versus mini posterior, surprisingly early clinical results. At 2 weeks, more direct anterior patients required gait aids. At 8 weeks, direct anterior patients had a higher mean Harris hip score, but interestingly, a lower return to work and driving with no difference in their use of gait aids, narcotics, ADLs, or walking half a mile. Interestingly, there were more wound problems that occurred in the mini posterior, and that was also surprising, but that was actually shown in another study as well. Are there differences in gait mechanics amongst different surgical approaches? And the answer is no. If you look at this JBJS reviews paper in 2018, they looked at 19 studies, over 700 patients. They did step length, hip adduction moments, etc. And they determined that whether the reported post-op gait value differences are clinically meaningful remains a substantial challenge for the interpretation of these findings. So again, a lot of questions still persist. And if you go across the Atlantic Ocean, this prospective randomized trial from France showed that early functional results and objective locomotor parameters were comparable between the anterior and posterior approaches at 3 to 12 weeks. So again, it just kept on, it keeps on making me wonder, you know, why are people doing this? How about less pain early on in a direct anterior? This was an interesting way, the way this was written. This was from Europe. Early gain and pain reduction in hip function, but more complications following the anterior minimally invasive approach. So interestingly, this compared the direct lateral to the anterior. So this was not the posterior approach. And perhaps when you compare it to the direct lateral, which very few people are still doing, certainly in New York, there may be an advantage to the direct anterior. The other question is MIS direct anterior muscle sparing? So these fellows, and I believe Bill Hozak from Jefferson is still doing anteriors. He's a big anterior proponent. So they compared the supine direct anterior described by Kegi to the lateral decubitus mini posterior lateral that Dor described, identical implants and sizes. And what they showed us, this was a cadaveric study, a direct anterior may spare the hip abductors more than the posterior. All specimens in the direct anterior had TFL damage, 31% of the area, and direct head of the rectus. And this was interesting. The piriformis or the conjoint tendon was transected in 50% of anterior approaches to mobilize the femur. So these are surgeons, experienced surgeons, reputable institutions that are still doing the anterior, and this is what they reported. And interestingly, Jose Rodriguez, here he comes once again with some young surgeons, John Cooper and Kamara. Kamara's over at Einstein, and John, I believe, is a speaker also. He's at Columbia. And interestingly, they really did a phenomenal job showing the exact way to transect muscles during the anterior approach in order to have good visualization. In fact, these are the steps right here. You can read them in Essential Surgical Techniques in JBJS, where you release the conjoint tendon, you flip the piriformis posteriorly, you release the piriformis, and luckily only rarely do you have to remove the obturator externus. So the question is, does this muscle sparing approach lead to better short-term or long-term outcomes after direct anterior? And if you look at this study from Mass General, there was no evidence of superior patient-reported outcome scores at total hip, neither at 1.5 months or at 5 years postoperatively. Again, an ACUS Clinical Research Award paper. So how about other important things? Things like the learning curve, the lateral cutaneous nerve injury, infection, dislocations, fractures, and loosening. Well, this study from the Netherlands, looking at learning curve, showed, again, increased blood loss, greater complication rates versus posterior, and the surgical time was also doubled, probably in the first 50 or so cases that are done. And this other study from the Netherlands also showed that this learning effect really stops after about 50 patients or so. But everybody agrees that this is technically challenging. Again, not everybody is as superb a surgeon as Darwin Chen. He truly is gifted. But it's challenging. It's challenging in obese patients and muscular patients and patients with short femoral necks and patients with protrusion. And forget about all the other patients that have other problems that we have to deal with during hip surgery. And interestingly, right, so if you look at this study, surgeons with an annual volume of more than 50 procedures performed approximately 1/6 of the primary hip arthroplasties. So here you have a learning curve of 50 patients or so, yet the majority of surgeons that are doing hip replacements in the United States are not doing 50 a year. And they're exactly the ones that are trying to increase their volume, get their name out, saying I'm doing this minimally invasive muscle sparing approach. And unfortunately, they're the ones that are probably going to get in trouble because they're not going to get to 50 for a very long time. How about the lateral femoral cutaneous nerve? Several studies that looked at this. The Hopkins group showed about a 14% incidence. This group from Europe, 21% incidence. And most of the time, this is just a little bit of numbness, but sometimes patients could have more neuropathic pain, although that's rare, but it does bother them. And it bothers them when they see that incision anteriorly, and sometimes depending on their preference, it bothers their spouses and their partners. How about infection risk? Well, Darwin alluded to this. This was a really nice institutional study that won the Stinchfield Award. Close to 2,000 patients in the direct anterior, over 4,000 patients in the other groups. And surely some of these surgeons were not the high volume surgeons at this institution, although certainly the high volume surgeons put their name on this paper. But after multivariate analysis, the direct anterior approach was 2.2 times more likely to result in PJI as compared to the non. Interestingly, this paper from JAMA, a pretty reputable journal, they did a population-based retrospective cohort study, close to 6,000 propensity score match patients. Direct anterior has significantly greater risk of deep infection that required surgery. Now, I don't know whether these surgeons were experienced or not. The joint disease surgeons apparently were not, and they were not high volume. But these authors postulated that the higher infection risk could be due to the proximity of wound to the anterior groin fold, less robust fascia, use of intraoperative fluoroscopy, and longer operative times. If you look at this recent study that's actually still in press with JBJS, 122,000 joint replacements from Australia, they showed a lower rate of revision for infection after direct anterior. But these are only patients that had osteoarthritis, so they did not include things like rheumatoid arthritis and things like that. And this was influenced by database deficiencies such as unknown indications for direct anterior versus non-direct anterior. And infection was not recorded if the component exchange was not performed. So again, it's unclear whether patients may have just had a washout, and those patients would not have been included in this approach. Wound complication risk, very interesting to me. John Cooper and Rodriguez reported 11%. 2% of these required other interventions. Mayo Clinic study showed 11% incidence of wound complications. Guess what? In the posterior approach. So again, a little bit surprising. I could say I have not had a lot of wound complications in the posterior approach, except when they have a deep infection, and at that point, it's not a wound complication. Then it's a deep infection. So interesting to look at. But perhaps there's more to come about infection. If you look at this really nice study that was done out of Doug Dennis's group, they actually did dermal punch biopsies on different parts of the thigh, and they showed that of all positive cultures, 65% were obtained from the anterior location, of which 60% were from the most proximal biopsy location. So approximately 14% of patients demonstrated a positive Cutibacterium, which is P. acnes colonization about the hip, and the majority of these were anterior. And so I think we're going to learn more about these. As we know, P. acnes or C. acnes infections they take a long time to brew. They may be implicated in loosening down the road. So again, the infection numbers for the anterior approach, I can't predict, but I do expect they will increase over time. How about revisions for dislocations in Australian and Norwegian registries? These suggest higher rates of revisions for dislocations for posterior approach. Okay, so this is the Australian registry and the Norwegian registry, relatively high numbers. If you look at the Kaiser Permanente registry from California, these show a higher hazard ratio for posterior approach, but it's really only 0.39. And they basically show low risk of dislocation with the anterior approach. But if you look at other studies, and anything that comes out of California, I always take it a little bit with a grain of salt. But this Michigan registry, I don't know, maybe Michigan also, but there's no difference in dislocation seen in anterior versus posterior approach. Okay, so they looked at I believe it was 2,100 matched pairs. And in this study from Joint Disease, again, an institutional study, now they looked at dislocation rate. They did not look at revision for dislocation, and they showed an equal dislocation rate between the anterior and the non-anterior approaches. The non-anterior, most of these were posterior. So you kind of wonder, right? Anterior approach, if not done right, it's likely it's going to dislocate anteriorly. Those are the ones that I've had to revise that have come across my desk. And the posterior approaches, they're probably more likely to get a revision, because once they dislocate once, they're going to become unstable. So it's really hard to know. So again, I think there's a suggestion that dislocation risk is lower through an anterior, but again, I don't think that that's that clear. And if you look at other institutional studies from again, reputable folks, Bill Hamilton is a big proponent of the anterior hip approach, and he showed no difference in dislocation when he does an anterior and a posterior. How about loosening? I think very few people will argue that the anterior approach does not have a higher loosening and fracture rate. Again, if you look at this Australian registry, large numbers, that's very obvious. And other studies on loosening support the Australian registry. Data from the Swedish registry and Dutch registry showed higher loosening for direct anterior, and in fact lowest for posterior. And again, this may increase over time due to other factors like infection. But let's talk a few more things to ponder about the anterior approach. And these are just things that I think about every time I revise one of these. The position of the cup, right? They say, well, you don't antivert the cup as much because you don't want the hip to dislocate anteriorly. That's what Bill Hamilton taught me when I spent time with him, when he taught me how to do it. And that predisposes these patients to iliopsoas tendinitis. I mean, we know that cup overhang leads to iliopsoas tendinitis, but then you listen to guys like Jose Rodriguez that say, well, you know what, use a smaller cup. So now I'm going to use a smaller cup, and the only way to put a smaller cup and then still get good fixation is to put it slightly proximal, right? If you put it down inferior, medial, and slightly anterior, which biomechanically is the best spot for cups. So now we're changing the biomechanics just so that we don't get iliopsoas tendinitis, just so that we could do an anterior approach. Surgeons often change fixation philosophy, stem design. We all know that companies are constantly struggling to come up with new stem designs, shorter designs, less curves, less that, in order to accommodate the surgical approach that's being marketed. And even cementing. I know John Cooper is a big proponent of cementing some of these patients, because guess what? You don't want to fracture, right? So if you have an osteoporotic bone that you could easily do a cementless stem and a posterior approach. Now we're going to cement it. Not that there's anything wrong with cement. Cemented stems do phenomenally well. They do as well as cementless stems. But when I was doing these, at least in the ones that I've seen, that MATA table, it kind of bounces on the floor as you're mounting the broach in, and you really don't get that feedback that you do in a posterior approach. And what are you going to do? Well, listen, I'm afraid I'm going to fracture the femur. I'm going to undersize. I'm going to rely on a fluoroscopic imaging to size my stem, not on how it actually feels. And I'm just going to undersize it because I don't want it to fracture, because to fix that fracture is a big deal. There's no opportunity when using the fracture table to check combined anteversion and assess stability. Relying on the posterior cortex to place femoral anteversion. We note that the neck cut heights affects the way the cortical version looks. Right there's an anterior bow in the femoral diaphysis, and there's a posterior bow in the metaphysis. So these are all things that are affected by the neck height. And when you do an anterior approach, you're only looking at the bone. and it's very difficult, in my opinion, to properly place the version. And I've actually revised 2 patients that have had an anterior approach that were impinging. They weren't dislocating, but they were impinging, and they had polyethylene edge loading and wear, and it was purely because the stems were placed parallel to the posterior cortex. A few more things. It's a 3D operation that we're turning into a 2D operation. Again, it jeopardizes cup placement. On the fluoroscopy, you can only see medial, lateral, proximal, distal, right? And you can't really place the anterior posterior axis, which is very important. If you posteriorize the cup, you're going to get impingement and you're going to get long-term problems. Increased number of OR personnel and their responsibility, reliance on reps to manage a table. All of a sudden, now we have more people in the room, more infection risk. You have to wear lead, expose yourself to increased radiation over the course of your diminished career. Who knows? You know, there's some studies that looked at that, but it certainly scares me, and it scares my wife. Although I don't know, she tells me I'm more dead than alive, so maybe I should start doing anteriors. Femoral nerve palsy, much more devastating than sciatic nerve palsies for obvious reasons. And extending the approach is just more challenging, especially and it's extending the approach is even more important for MIS approaches. Last but not least, what are the ethics of marketing direct anterior? This was a very nice article in Journal of Arthroplasty where over 1/5 of ACUS members promote direct anterior on the internet. And when you look at the member sites, things like faster recovery and decreased pain are approximately 9 times more frequently cited than any potential risk of the procedure. These guys, they said, while ACUS policy does not regulate member marketing, it is a responsibility of all orthopedic surgeons to disseminate accurate, validated information concerning the procedures we perform. So it's really disappointing what's happened with the marketing of DA. Luckily, all the panelists in this conference, none of them do any dishonest marketing. If you look at this large registry from England, Wales, Northern Ireland, and the Isle of Man, quite a lot of operations here. Their final conclusions, we recommend the posterior approach should be considered the current standard for total hip replacement. This was from 2020. So in conclusion, there are multiple approaches, all ultimately lead to great outcomes. None of them are free lunches. I'm glad Darwin used that term as well. I believe we learned it from Aaron Rosenberg at Rush. They all have potential complications. If you decide to try a new approach mid-career, take a course, practice on cadavers, and find a mentor, somebody you could scrub in, somebody you could go to his institution, you can come to yours, you can call him and ask for advice. And get good at one approach for primaries, be honest with your patients about the benefits and the risks, and just enjoy it, have fun. Hip replacement surgery, one of the marvels of medicine. It's a fun operation, and to me, doing the anterior just takes the fun out. Thank you very much.
Thanks, Colin. Babette, do we have any questions?
Yes, we have one question. How often do you see patients with PSOAS irritation? It's rare in my experience. I know I didn't say that right, so I apologize. But I did my best.
SOAS.
So, I mean, well, Darwin, you go first. I mean, you're doing anteriors now, so I stopped doing them after 2029.
Yeah, incidentally, I've noticed no difference in psoas or hip flexor irritation regardless of approach. I think a lot of it has to do with how you position your cup regardless of where you enter. If the anterior wall or the cup is tucked in the anterior wall, you're going to be in good shape.
It's interesting, Jose Rodriguez seems to make a big deal out of it, so I don't know if his patients, you know, I mean, that he has a whole talk on tucking that cup.
Yep. No, I've certainly learned a lot from Jose and right. In how to position a cup, but I don't think it necessarily is different from DA. I do think that anterior hips do get some more groin pain because you do in harder hips elevate the indirect head of the rectus off the capsule a little bit, and then they certainly in my practice do have a little bit of hip flexor weakness for their early first few weeks. That goes away completely by the second post-op visit.
I have one question. In the direct approach, you're clearly having to use fluoroscopy.
Mm-hmm. You don't
Has
have
the
to.
amount of radi-
It's just an
What?
advantage of doing it that way. You just have the ability to use it because you're in supine position and you have a radiolucent table to use, but you don't have to use it at all.
So has the amount of radiation used in these procedures been looked at?
I don't know of a study that looks at that. It's certainly something that I think is something to be concerned about. So the amount of fluoro shots you take, I think is directly proportional to your comfort level and how many hips you do. I'm certainly taking less fluoro now than I did when I started doing this. And I think it's just important to practice good fluoroscopic technique, backing away when you take a shot, using lead glasses, using good lead, taking your hands out of the equation, out of the beam, so that you can have a long career.
I have a question for Darwin. In interpreting the registry studies, one of the things that I had trouble with was, how much are, and you've done some of your training in Europe as well, how much of the surgeons in Europe are using the table as compared to the United States? I mean, it's probably hard to know for sure, but
Yeah, I don't think
as much, or
that's it. I don't think that's in registry data. Certainly, my experience in Switzerland and what I've heard from Germany is that they don't use fancy tables, they don't use fluoro, they just go from the front. And yeah, I don't think that necessarily plays into it as much. I think the radiolucent table, the fanciness of the table and fluoroscopy, I think is a more uniquely American experience.
Great. Well, thank you to both of you. I think the debate continues, and in a few years we can do it again.